Sir, please start. We are live.
So good evening, everyone. I am Dr. Viswajit from the Medical Services team at Zydus, and I welcome you all to this scientific session called BemTalk on the topic Bempedoic Acid in Uncontrolled LDLc. So today we have with us one of the most reputed doctor, I would say, Dr. Yogesh Kothari, sir. So briefly about sir, so sir is a senior interventional cardiologist and an electrophysiologist and the head of the Department of Cardiac Science at Bhagwan Mahavir Jain Hospitals. Sir is also the faculty working as a professor of cardiology and electrophysiology at Raja Rajeshwari Medical College, St. John Medical College, and SVIMS Tirupati. So, sir has a vast experience of more than 15 years in academic institutions and also working in various corporate hospitals like Apollo Gleneagles Hospital. Sir has keen interest in research and publication and is also publishing various articles in national and international journals on various large phase 3 and phase 4 clinical trials. So with this, I would like to welcome sir and hand over the academic proceedings to sir. Over
Thank
to
you,
you.
Vishwajit. Thank you, Vishwajit. Can we have the slides, please? And thank you for the kind introduction. Yeah. Hi, good evening, everybody. I think today is a day for a very interesting topic called bempedoic acid and its role in the management of dyslipidemia, especially uncontrolled LDL cholesterol. What is the concept of the therapy and how we can use it for our better efficacy is what is going to be the points of discussion today. Next slide. So whether irrespective of primary prevention or secondary prevention, uh, uh, we always know that lipids play a central role. So if you look at all the risk factors of dyslipidemia, smoking and all the risk factors of atherosclerosis, if you look at them, smoking and dyslipidemia are the two major factors. And, they together contribute in a major way. And hence, lipid targets are always been the focus and very, very important in the management of both primary prevention and secondary prevention of a cardiovascular event. Next slide. So these are all the primary prevention trials where statins were the drug of the choice. They included the ALERT lipid lowering therapy arm, ASCOT lipid lowering therapy arm. These two were hypertension trials which had a lipid lowering arm. And then CARDS was there. Then CHS, Prosper, Jupiter. Jupiter was a very, very, very important primary prevention trial involving 17,000 patients with rosuvastatin 20 milligram. And there was a 44% reduction in non-fatal MI. And so all the trials when we see, statins have always been the center of the therapy, be it lovastatin, pravastatin, or atorvastatin. And the recent ones were rosuvastatin. When we look at secondary prevention trials, starting from the Scandinavian Forest trial to the treat to new targets, that is the TNT trial and the IDEAL trial and the Prove It Timmy 22 trial, all of them, again, statins are always the drug of choice. And there was a significant 35 to 40% reduction in the LDL cholesterol level with these moderate to high intensity statins in the secondary prevention trial. And not only that, with the reduction in the lipids, there was also a significant reduction in the event rate, proving the point that dyslipidemia is the major concern as far as CAD or atherosclerosis is concerned. And reduction of the LDL cholesterol should be one of the important targets in managing these patients. Next slide. But there are few concerns in the management of dyslipidemia. And statins are first line of therapy. We all know that. But with statins, there are some concerns. Not all statin users achieve the LDL cholesterol goal as per the guideline directed recommendation. And secondly, Many patients do not tolerate statins, or they tolerate only low dose statin. They don't tolerate moderate intensity or high intensity statin. So, what to do with this group of patients who do not tolerate either any statin, or they do not tolerate moderate to high intensity statin? So, in such patients, what do we do? So, these are the two main concerns uh, with the statin therapy, which which we always needed to address. Ezetimibe was there, but it was only partially efficacious. So there was always a search for a new drug to address these concerns. Next slide. So do all statin users achieve LDL cholesterol as per guideline recommendation? So let us look at this data. So lower is better for longer prevention, and these are all the important trials where they showed that um, nine trials, statin trials, then ezetimibe trials, everything. So with all the trials, they showed that they brought down the LDL cholesterol to lower and lower levels, which was associated with a better outcome for the patients. Next slide. So this is the guideline. If you look at the European Society of Cardiology guideline of 2016 versus European Society of Cardiology guideline of 2019. In low risk category of patients, the previous guideline was 115, which is unchanged. When it comes to moderate risk patients, in European Society, in 2016 it was 115 LDL target, whereas in 2019 it is 100. And in high risk patients, which was 100, and now it is 70. And very, very high risk patients who had multiple events or have a strong family history and all those type of group of patients, the previous target was 70, and now it has been reduced to 55. And to achieve these kind of things, you definitely need something beyond statins. And as cardiovascular risk increases, need to reduce LDL cholesterol more and more is a very, very important point, indicating again the central role of LDL cholesterol in atherosclerosis. So based on the revised guidelines, how do we know how many patients have controlled LDL cholesterol or have achieved the target of the AAC 2019? Next slide. So, uh, so 18 countries of Europe were involved, and total number of patients were 5,888. 3,000 were in the primary prevention arm, and another 3,000 were in the secondary prevention arm. And the objective of this small Da Vinci trial was to see how much of LDL cholesterol goal has been achieved by the patients with statin alone. Next slide. So, proportion of patients receiving lipid lowering therapy. Overall, 27% of the eligible patients were receiving high intensity statin. Out of 100 patients who needed high intensity statins, only 27 of them were receiving the high intensity statin, and 33 of the patients achieved lipid goals with high intensity statin. Uh, it's a very, very important to understand that only one third of the patients who were on high intensity statin could achieve the lipid goals based on the ESC 2019 guidelines, which is less than 55 and less than 70 for high risk and very high risk patients. Next slide. So, as per the ESC 2000, so we already discussed that 37% of patients were receiving high intensity statins, and 18% of the patients achieved the lipid goal with these high intensity statins. Next slide. So, what is the clinical benefit in attaining LDL cholesterol goals? Next slide. So, this is a Korean nationwide cohort study, prevention for patients with uh, low, treating the patients to target LDL, and secondary prevention for patients with acute AMI. And total number of patients were 5,000 patients with prior history of myocardial infarction. LDL cholesterol achievers definition was reduction to more than 50% of baseline at the time of index MI, and reduction to less than 70 milligram per deciliter. So one of the two were the main endpoints that they were looking at. And the study endpoint was 2-year major adverse cardiac and coronary events, cardiovascular and coronary events, including cardiovascular mortality, recurrent MI, ischemic stroke. And the follow-up period was 2.1 years. And 94% of patients were on moderate to high intensity statins, and LDL cholesterol was achieved in 22% of the patients. Relative reduction was 37% with a p-value of 0.04, which was highly significant. And this, in conclusion, showed that patients with acute MI achieving a target LDL cholesterol is associated with definitely a lower incidence and a reduced hazard for recurrent clinical event. Next slide. So this is the graphical representation of the data where they showed a significant reduction uh, of event rate with moderate to high intensity statin and the follow-up period of 3 years. So next slide. So how to achieve LDL cholesterol target after maximum tolerant dose of statins have been given. So we know that statins are the first line of agents, but beyond statins, what do we do is the main concern that we had. And next slide. So this is the uh, slide showing what each therapy does. So basically, a moderate intensity statin reduces by 30%. A high intensity statin reduces the LDL by 50%. High intensity statin plus ezetimibe reduced by 65%. PCSK9 inhibitor reduces 60%. PCSK9 plus a high intensity statin reduces by 75%. And this is 85% reduction, which can be achieved by a combination of PCSK9 plus high intensity statin plus ezetimibe. Next slide. So bempedoic acid is a very unique drug. It is first in class drug in this class of molecules. And definitely more research would happen and more molecules would come out in the future. But this is the first molecule in this class. Can you just go back to the previous slide? So it basically is a ATP citrate lyase so inhibitor. So this is a enzyme in the cholesterol synthesis which is upstream to HMG-CoA reductase. So this ATP citrate lyase inhibitor, so that is how bempedoic acid acts. Next slide. So it is approved USA, European Union, and now it is approved even in India. Approval in US and European Union was in 2020. And the main indications are reduce uncontrolled LDL cholesterol in patients with maximum tolerated statin dose, mixed dyslipidemia, familial hypercholesterol, high risk of ASCVD patients. Statin intolerance or no statin is contraindicated again becomes a very important indication for bempedoic acid. And the dosage is basically 180 milligram orally with or without food. Next slide. So this is the mechanism of action, liver in the skeletal muscle, and it is excreted by the kidney. So uh, basically, acyl ACVL 1, so ACL enzyme and bempedoic acid acts there, and that is upstream to the HMG-CoA reductase where statins act. And next slide. So it's ATP citrate lyase, basically ACL, ATP citrate lyase. So half-life is about 21 hours. Elimination is 70% through kidney and less than 2% through unchanged, 5% through feces. So renal impairment, no dosage adjustment is required, but it is not studied in end-stage renal disease. Hepatic impairment, no dosage adjustment required, and not studied in patients with child pug class C severe cirrhotic patients. It has not been studied as of now, but so we can say that severe liver disease we should be cautious because it has not yet been studied. But otherwise, in the routine patients, if there's a mild hepatic impairment, there is no contraindication. And renal impairment also up to moderate renal disease, it has been studied. It has not been studied in end stage dialysis dependent renal disease. So most important is to monitor hyperuricemia and gout in all patients, and patients more than 60 years of age taking corticosteroids or fluoroquinolones, or patients with renal failure, it needs to be cautious or avoided. And so that is the main thing. Breastfeeding, pregnancy are again contraindications. So next slide. So these are the important trials: the clear harmony, the clear wisdom, the clear tranquility, and the clear serenity. These are the four important trials, all for duration between 12 weeks to 52 weeks, where they took patients either for primary prevention or patients with statin intolerance. And some trials were having background statins, some trials did not have background statins. So let us understand the trials and how were their outcomes. Next slide. So these are the clear harmony and clear wisdom, where almost 90 to 100% of patients had background statin therapy, and the patients were given 52 weeks of therapy. And efficacy endpoint was percentage LDL reduction at 12 weeks, and safety endpoint was overall safety outcomes at the end of 52 weeks. So this is the clear wisdom trial. Next slide. And clear harmony. So there's a significant reduction, as you can see, with bempedoic acid in the mean LDL cholesterol level, and which was sustained throughout the trial period. So there was an acute reduction in LDL cholesterol by 4 to 8 weeks, and that reduction was sustained throughout the trial period. And if you look at the total cholesterol, a similar effect. If you look at ApoB, again a similar effect. Next slide. So 18% reduction in the LDL cholesterol. Next slide. There is a clear wisdom, a feature which was very similar to clear harmony, where there was an initial reduction by 4 to 6 weeks, and that reduction was sustained up to 52 weeks. And there was a 17.4% reduction in the LDL cholesterol as opposed to placebo in the patients with background statin therapy, with a p-value of less than 0.001, which was very, very highly significant. Next slide. So number of patients is the tranquility and serenity. Here, the number of patients on statins were much lesser, just 32% and 18%. And again, the similar efficacy and safety endpoints, but it was a shorter trial, 12 to 24 weeks. Next slide. So there's a 23.5% reduction in LDL cholesterol, which again translates into reduction in the non-HDL, total, and ApoB. And percentage mean of LDL cholesterol reduction by bempedoic acid at 12 weeks was almost 28% compared to placebo. So if you look at the placebo corrected, so 23 plus 5, 28% reduction in the bempedoic acid group. Next slide. So this is the serenity results. Again, a 21% reduction in the LDL cholesterol levels. Next slide. So when we look at bempedoic acid or ezetimibe alone or in fixed dose combination versus placebo, so you can see so this is ezetimibe alone, bempedoic acid alone, and when we combine the two, there's almost a 36% reduction in the LDL cholesterol level. Next slide. So based on the clear outcomes, 14,000 patients in phase 3 trial, enrollment is completed. Completion will be by December 2022, this trial, and the results will be out after that. So in 2023, we will get the results of the global cardiovascular outcome trial based on the clear outcomes. And this will be more of an outcome trial rather than just the LDL cholesterol reduction. And the primary endpoint will be MACE, that is the major adverse coronary event, including cardiovascular death, non-fatal MI, non-fatal stroke, and coronary vascularization um, in minimum of 16-20 primary four-component events for at least 2 years. So that is the duration of the trial. So probably in 2024, after enrollment is completed, and 2024 end or 2025, I think these results should come and give us the outcomes of the. We have already studied the LDL cholesterol reduction. How that translates into outcomes is going to be clear from this trial. Next slide. So ADA20 bempedoic acid mentioned bempedoic acid as lipid lowering agent in high risk patients. Next slide. So is there any evidence of reduction in inflammatory markers with bempedoic acid? Next slide. So uh, basically, we all know the mechanism of action of bempedoic acid and how they can also reduce the inflammatory markers. Next slide. Especially HSCRP and other markers. So this is a 22.4% reduction in HSCRP from baseline. Uh, and when you combine it with bempedoic acid, it is 32.5%. So there's a significant reduction in HSCRP levels with bempedoic acid as opposed to placebo. Next slide. Hyperuricemia is slightly higher, which leads to increased incidence of gout, which needs to be monitored. Liver enzymes are similar. Anemia, not much different. Tendon rupture, because elderly, we have to watch for any tendon related issues. If they have any tendon issues, then we need to be cautious or avoid bempedoic acid. New onset of worsening diabetes is not significantly different, unlike statins. Next slide. So, in summary, uncontrolled LDL cholesterol is a major risk factor for cardiovascular disease. Statins are the first choice of therapy for any type of dyslipidemia. Even after use of high density statin, 70% of the patients have uncontrolled LDL cholesterol, and it leads to a residual risk of 60 to 70%. And bempedoic acid is a first in class agent having unique mechanism of action of ACL enzyme inhibition. And there's a significant LDL reduction up to 18% from baseline and 28% in statin intolerant patients. And it is safe in mild to moderate kidney disease. And the most important adverse event to watch for are hyperuricemia and gout, which should be monitored in the follow-up of the patients. With this, I would like to end the presentation and would like to take any questions that may be there.
So yeah, thank you for the wonderful session, sir. So we do have a few questions, sir. So one question is from Dr. Kumar. So he's asked the question, what should be an ideal patient profile who should be put on bempedoic acid?
So I think patients, one is very important to monitor the cholesterol levels of your patients on statin therapy. Many times, the LDL cholesterol levels are not monitored. So when you're following up your dyslipidemia patient, either a primary prevention or a secondary prevention, and if you see that the LDL cholesterol level is above 70, especially in high risk or very high risk patients, like if it is like 90, 95 on statin. I think these will be the patients you should consider an addition of bempedoic acid so that you can bring it down to below 70 or below 55 as per the group of patients. The second group of patients, as we already discussed, is patients who are having statin intolerance. So here bempedoic acid probably, and probably in addition to acetyl may be a good choice. And if the patient can afford, a PCSK9 inhibitor also can be given.
Agree, sir. So one question is from Dr. Anupama that what are the side effects of bempedoic acid and how it is better than ezetimibe?
Yeah. So acetamide is basically more GI related effect, whereas bempedoic acid has the liver in the cholesterol metabolism. So that is the main advantage of bempedoic acid over ezetimibe. So ezetimibe has a very dose related this thing. So it is basically acts very locally in the GI. So that's why it will not have the complete desired effect in some patients. When they have a very high cholesterol, so this acts on the upstream cholesterol synthesis. So that's why it is going to be very helpful. So that is how it is better. And it can be used synergistically because in some patients who have very high cholesterol, uh, you can combine STMB and bempedoic acid both.
Right, sir. So there's a third question, sir. So from Dr. Atul. So it's just asked question like, is there any guidelines like ADA or EAC that has mentioned this data or acknowledged this data, sir, of
Yeah,
bempedoic
yeah.
acid?
So bempedoic acid is now approved both by ACCHA and by European Society of Cardiology as a lipid lowering or an LDL cholesterol lowering drug, especially in patients with statin intolerance. And I think once the trial outcome data comes, that is the large outcome. See, most of the guidelines are based on outcomes. So as of now, the label indication has been given. But once the outcome data comes, then a stronger indication would be given after that evidence is there.
So we'll take two more questions, sir. So the next question is like, can it be given with ezetimibe without initiating statins at the very first place?
So I think statin form the cornerstone of therapy. So we should not avoid statin unless the patient is fully statin intolerant. So if the patient is statin tolerant, we should give them statin and look at the residual risk and look at the residual LDL cholesterol reduction that is required. And if those goals are not met, then you should add the bempedoic acid. So you should not give it as a substitute for statin. Whereas in a patient with statin intolerant patient, where patients do not tolerate any dose of statin or only tolerate low dose of statin, so in such patients, definitely you can give bempedoic acid and you can combine it with ezetimibe.
So I'll take the last question, sir. So that the question is, how suitable will be bempedoic acid for Indian population where statin is basically the first choice?
Yeah, again, we all know that in Indian patients, statin intolerance is like the Western population, quite a big problem. So definitely it will have its place, especially in statin intolerant patient. And secondly, Indian patients have a lot of residual risk. They have a very high non-HDL cholesterol. And this non-HDL cholesterol can be addressed by the bempedoic acid.
So I think with that we have come to the end of the session. So, sir, any final round of comments from your end?
So I think the two important things is basically look at what the target for your patient is. So be aware of the target for the particular patient that you're treating. So every patient you can mention what is the target LDL cholesterol so that you are aware of the target. And once you are aware of the target, if there's any residual risk that needs to be reduced, then you can add bempedoic acid, which does not worsen the tolerance, which does not have liver side effects like statins, no increased incidence of diabetes. Hence, we can safely add bempedoic acid uh, to moderate to high intensity statin.
Right, sir. So thank you so much for this
Thank you.
wonderful session.
Thank
And
you very much. Thank you,
thanks.
Vishwajit.
Thank you, sir.
Thank you.
I'll connect again maybe in future for similar kind of a session. I think all the queries has been duly addressed, and we do have good takeaway messages also from this session. Thank you once again, sir.
Thank you. Thank you.